So what I want to talk about really this evening is periradicular surgery, so management of the root end on the left-hand side. Now, if we have time at the end, I would like to talk a little bit about other adjunctive surgeries for endo, such as management of external cervical resorption, maybe perforation repairs, bits and pieces like that. So it's really just to give you a flavour of endodontic microsurgery. We're not just talking about, you know, historical apicectomy stuff here. The way I'm going to divide the evening up is probably into about 45 minutes, because I do appreciate it's everybody's evening. But the pathogenesis from a biologically driven treatment plan, I think, is really important. So I want to go through just a little bit of pathogenesis. It's not, you know, it's not my strong suit, but I want to. It's definitely important. Indications are helpful, but sometimes I find the absolute contraindications are more helpful. So I want to go through the contraindications and make those very clear for periradicular surgery. The assessment is critical, because if we don't do the right assessment, we come to the wrong diagnosis, we end up inevitably doing the wrong treatment and don't help anybody. So I've got some clinical cases that we're going to go through in meticulous detail for assessment. And then obviously, look, I'm a clinician, I love doing the hands-on bit. We'll probably spend the majority of the evening talking about the surgery, and I have a bunch of videos on the surgery. As we go through, I've got a couple of questions for everybody, but in the questions box, I'm happy, you know, it's a casual chat through periradicular surgery. So if you stick some questions in at the time, myself or Ryan in the background, who's on admin with me, will very helpfully try and field those questions to me and interrupt me if I just get into a flow talking about some, you know, niche detail of surgery, but to then draw it back to, you know, your specific questions. And really the first question that I wanted to pose to you, just to make sure everybody's there and listening, and that I can work the actual IT, was to get an idea of everybody's experience with periradicular surgery, so that I can maybe, you know, if we've got a bunch of very experienced clinicians, well, then I can maybe tailor to that. If we've got a broad range, well, then I'll keep broad strokes. If, you know, if we've got people that are, you know, starting out in their periradicular surgery, well, then I'll make some, you know, very specific kind of indications. So this is the poll. I've launched it. Ryan will keep me right in the background, but you know, when I'm talking about these numbers, I'm talking about, you know, in the last, you know, couple of years, obviously, we've had a wee bit of a difficult situation with treatment recently. Okay, so that's kind of the majority of you voted. And what would you know? It's nearly a third, a third, a third. So that's great. So we've got a range of experience with periradicular surgery. So please then stick. I think I've got a good level of detail in here to explore niche bits, but also some broad brush strokes. So please stick your comments in the questions bit, and I shall keep an eye on I'll keep an eye on the questions, and so will Ryan. Okay, so first slide. You've maybe seen this before, but this patient comes in and has vague symptoms of periradicular disease, so occasional discomfort over the apex, occasional discomfort to tenderness to percussion. The root treatment was done about 8 years ago. You take the radiograph. What would your preferences be here? So here's the next poll. Okay, so again, that's the majority of you voted, and we turned out about 10% monitor, 70% re-RCT, 8% periradicular surgery, and 4% XLA. Okay, let me close that. So I was a wee bit sneaky. I didn't give you the full history that I would expect to take from a history when you're dealing with something like this. But we all have internal biases. We all have things that we like to see, things that we don't like to see, treatment preferences. And really what I'm trying to demonstrate by this slide is that reading a radiograph can be interpreted from many different, pardon the pun, angles. This was the bit of GP, the single GP point that I pulled out from that root canal system. The Hoching biofilm, you can nearly see the bugs jumping off it. You can see the fur growing on that GP. I think we would all agree that in comparison to the radiograph and actually what we have clinically, that endodontic treatment isn't or wasn't ideal. A very well-known clinician once said, it's not what you put in, it's what you take out that matters. So if I was looking at the radiograph critically, I'd say, well, okay, the coronal restoration isn't, subcrestal, and the obturation looks good and it's well compacted all the way to the apex. But when we've got more and more systems going to a single file and single master GP cone, that all adds up to making post-op radiographs look good, but it gives you no idea about the level of decontamination about your root canal system. So, that's the result. A year later, endodontic retreatment, the lesion healed, and we had a successful outcome. So what I would like to kind of focus everybody's attention to is that over the next couple of 5 minutes, the pathogenesis, we have to identify the etiology and form a treatment plan around that etiology from a biological perspective. This was a paper published in the 80s, talking about how we should look at the biological fundamentals of our treatment, and how that if two of us looked at a radiograph, in about 30% of the time, we wouldn't agree. And then if I was to look at a radiograph and look at the same radiograph in a week's time or a month's time, and in about 15% of those cases, I still wouldn't agree with myself. And I think this is just another radiograph that really highlights this. A radiograph at a single snapshot in time really doesn't give you the full picture. Now, albeit you could say that that obturation doesn't look too hot, when you look in the pre and the post-op radiograph, you can see that there are positive changes in healing, such that, looking at either of those individual radiographs, you wouldn't have that full scope. And coming back to that internal bias, when we look at radiographs and we look at radiolucencies, we all get into the way of saying, oh, that's pathology. Well, from a radiograph, you can't technically call it pathology. All you can say that it's a radiolucency. The radiograph doesn't give you any definitive indication about what that radiolucency is. We all like to think that certain radiolucencies that look certain ways would suggest, for example, a cyst, but the only way to confirm what that periapical radiolucency is by the histopathology. And when you look at the histopathology from periapical radiolucencies, lesions that have then been biopsied subsequent to periradicular surgery, the vast and the most common one is a granuloma, and the second one is abscess. And that really, that takes account for at least 3/4 of the periapical radiolucencies that we see. And if it's a granuloma or an abscess, we know that endodontic treatment is going to be successful with that. Approximately 1/4 appear as a scar, and the classic or cardinal signs of a scar is that the radiolucency over here is distant from the actual apex of the root. It has a well corticated margin that you can see, but most importantly, there's no trabecular pattern in there, because this is a through and through lesion. So this is a lesion that at some point perforated the buccal plate, and also perforated the palatal plate. And that's why there's no little trabecular pattern in the radiolucency itself. Then when we come to talk about cysts, that actually makes up the least amount of what we identify from a radiograph. And I don't want to go into too much of the histology of it, but we have true cysts and pocket cysts. Recent evidence, so the recent evidence in 2020 there from the Journal of Endodontics would even suggest that a true cyst, so a cyst that technically or initially doesn't look like it has an epithelial lining attached to the root end, still will have a positive response to endodontic treatment if that tooth is judged to be necrotic or non-vital. So just because it's a cyst, there is no good evidence to suggest it will not respond to good endodontic treatment. So we just have to be careful of what we see and interpret on a radiograph. But what really is it that makes the root canal system or the root treatment that we've done fail? Well, the term failure, I suppose, is a little bit unfair. So more commonly now in the literature, you'll hear it called post-treatment disease, so PTD. So it's not really assigning blame. The most common one is persistent infection in the inside of the root canal system. So that's that's really due to either the bacteria, the fungi, or the virus will not dice up into which they are and which they aren't. But in the apical few millimeters, all those little ramifications and portals of exit, that are really, really difficult to disinfect with your irrigation, they are those little niches that's where all those little bugs hide. And if your endodontic treatment isn't going to work, that's where all those bugs are going to be that aren't going to allow your root treatment to work. A secondary infection would be then you've had endodontic treatment carried out, but either the coronal seal has failed over time, or you've actually introduced more bugs during your root canal treatment. So for example, maybe if you didn't use rubber dam or your rubber dam was leaking, that secondary infection is where the bugs get back in and repopulate the root canal system. So that can happen over time. But those two, so the first 2 points, the persistent and the secondary, are all inside. So that's why I've got this drain. They're all inside the root canal system. All those bugs are contained within the root canal system. Therefore, ortho-grade endodontic treatment will have the best chance to resolve that post-treatment disease. In only about 6% of cases of post-treatment disease is there a biofilm actually on the external root surface. So if it's on the external root surface, ortho-grade retreatment or treatment isn't actually going to help. At that point, you're definitely going to have to consider periradicular surgery because your biofilm is on the outside of the root. And just for completeness, I suppose I've included focal infection theory, and there's nothing being conclusively proved about that. It's there for further reading and just comprehensiveness of the content of this. So we know that endodontic treatment is successful. We know that we can access the bugs, and even if it is a mechanical issue, or an operator issue, that maybe we can't negotiate a curvature here, or we can't negotiate this curvature here, or we have an extra coronal restoration to then start to access the root canal system here. We do know that endodontic treatment has a high percentage success. Even endodontic retreatment has a high percentage success. Historically, Ing was quoted left, right, and center. But again, even from the 1970s and up to the 2020s, endodontic retreatment success is extremely high, in the high 80s, if not low 90s, depending on where you read. But it's not just the fact that it's potentially a mechanical problem to access the root canal system and disinfect it properly. When you talk about larger lesions and querying what that pathology actually is, again, these cases do show that ortho-grade endodontic treatment has a really positive outcome. And even if the healing isn't absolutely convincing, when you look at this middle case, this was a significant lesion. If we had have started to do any type of surgical procedure, we could compromise adjacent vital structures. The fact that this is now healed over the period of 18 months, or at least nearly healed over 18 months, if we needed to at this point to go in and do any type of surgery, we know that we're in a lot safer position in regards to the the adjacent vital structures. Likewise, and I don't know how, but this one healed very, very quickly, to the point that when I reviewed the patient, they were just about to have internal and external bleaching, and the original referrer had popped out some of the my original coronal seal to then go back and put bleach in these teeth, so that's why they look like that. But you can quite clearly see the lesion is healed up nicely. And even then, with some types of root resorption historically, we do have additional materials that can help the biological aspects of healing, so recreating the cementum over the end, and periodontal ligament potentially over the end of the root. So that being said, we know that endodontic treatment from an orthograde point of view works, but there's definitely instances where we need to consider surgery. So before we talk about the indications for surgery, what is it we're actually trying to achieve from surgery? Because if we don't know what we're going to try and achieve, well, then what outcome can we really expect? And this is something that I'd like to focus on. It's to resolve periradicular disease. So for me to be doing endodontic surgery, there needs to be obvious periradicular disease present, so that I know that that is something that I'm going to focus on to resolve for the patient. Now, obviously, the objectives are there that you can screenshot that. That's just gaining access and properly managing the root end. And we talked, as I mentioned, I would talk about the indications and the contraindications. That big elephant in the room, I will admit it, it's an elephant in the room. It's a very grey area, but what do you do with that heavily restored tooth? That is the biggest area, a grey area in decision making for endodontic surgery. Because if you see the case on the right hand side, this was a 3-unit bridge that the patient 6 months ago had spent £3,000 on, but now they ended up with periradicular disease associated with that lateral incisor. So, if you were saying to the patient, right, well, the absolute gold standard would be, we're going to dismantle your bridge, the post crown, and redo the endo, because the endo wasn't done at the time of your definitive bridge, it was done historically. And then we're going to put back your bridge and post, all being restorable. And the total cost of that is, in financial terms, the better part of £5,000. In time costs for the patient with provisionals, etc., that is a lot of treatment to undertake. And this is where there's a patient in front of you. It's just not a tooth. You have to be amenable to those types of conversations. Likewise, on the left-hand side, this was a long fibre post with an excellent fitting crown that had all just been recently done. And again, to dismantle that, to potentially end up with an unrestorable lateral incisor, these are difficult conversations that you have to have with your patients. For me, the indications, the absolute indications for periradicular surgery, sorry if you're a bit squeamish, or I've just put you off your dinner for that video on the right hand side, but most people like a bit of pus. Iatrogenic damage. So if for any, that's a file, so you can see on the left video that I'm pulling out a file from the periradicular tissue. If for any reason you can't access the apical foramen, there's a curvature, there's a perforation, there's a blockage, there's a fractured file, yeah, absolutely a reasonable option. Extra debris, foreign body, again, I'll show you a couple of cases of that. Those are definitely indications for periradicular surgery. And as I said, yes, endodontic treatment has a high success, but nothing is bulletproof. As we talked about, 6% of biofilms are actually on the external root surface, but that doesn't mean you can just use the excuse, oh, well, it must be on the external root surface. It has to be in the presence of a well-done endodontic treatment. before you start to look at the periradicular surgery side of it. And there's additional things like cholesterol crystals that you'll hear quoted around. So that's the kind of shimmery appearance on that video on the right-hand side. Excuse me. They promote an inflammatory reaction at the periapex, and so don't allow the body to heal quite as well. Biopsy is definitely reasonable if you are looking at a large lesion that you're not sure of the actual diagnosis, but you want to give orthograde endodontics a chance. Yeah, biopsy it, and sometimes that helps decompress the lesion as well. I've put investigation in brackets because if you can't figure out a diagnosis of periradicular disease, I would really be challenging you, going in and doing a surgical procedure on a patient for just an investigation is quite heavy-handed. We have a footprint that we have to be aware of when we're dealing with patients. Sometimes, most of the time, the first time to do anything is the best time. So losing those golden opportunities, they cannot be taken lightly. And certainly I've never just done a surgery just for an investigation. I would say these are some of the contraindications. So this is the next poll. So what do these have in common? So these are all referrals that I've taken, all for various, in fairness, not all for surgery, but at least 3 of them for surgery. The molar not so much for surgery. Yeah, so the vast majority of you have said, well, there's only about 50% of you voted. I'll leave you another couple of seconds. Okay, so we're up now a bit. Yeah, so 80% of you had said coronal seal, and that's the first thing that I look at when I'm looking at any type of endodontically treated tooth, to be honest with you. Big gap over here. This isn't even just a loss of coronal seal, this is caries. Big gap under the crown, big gap under the some sort of definitive restoration amalgam, secondary caries there. When we're talking about the pathology of periradicular disease, and we were talking about primary and secondary infections, this is all where those bugs are just washing into the root canal system. So fundamentally, your foundations of your treatment for that tooth are already compromised. So you're going to go and do a surgical procedure where the foundations of the coronal seal is already allowing bacteria to wash into the root canal system. You're on hiding to nothing. That is not a good long-term treatment solution for that patient. The other contraindication, sometimes forgotten about, I'll redo the poll for these. Slightly different question, but do you think these teeth are suitable for, well, not dice them, I'll dice them up, but just generally speaking. Yeah, so there's roughly 90% of you would say these aren't suitable for periradicular surgery. I talk about this to patients as well with endo. You can do the best endo in the world, but if you can't actually restore the tooth correctly, well then what was, you've lost, the patient's lost financially, both of you have lost out in time, which is precious to everybody, because the tooth isn't fundamentally restorable. The other thing, it's a little pet hate of mine, but when I see that amount of calculus on a radiograph, that's a reasonable amount of calculus. If I'm going to go and do surgery on someone, at least in the area that I'm going to do surgery, their oral hygiene has to be meticulous. It just makes your surgery a lot more complicated with the management of the tissue. Someone's asked me to change the screen display. I can't see the slides. Sometimes if you swipe left and right, if it's on a phone, if you're on your phone, there's 2 different options, so you can slide between the left and the right options on your screen. So yeah, fundamentally for me, these teeth, this is unrestorable. This is definitely unrestorable. The amount of plaque and calculus associated with these teeth and the poor endodontic treatment not suitable for periradicular surgery. The amount of periodontal bone loss with such a wide post and little remaining dentine is most likely a vertical root fracture. And, you know, redoing surgery, I think it was Einstein that said doing something over and over again and expecting a different result is the definition of insanity. You have to have a tangible gain of something that you're going to do differently if you're going to do the same thing or the same procedure again. What are you going to do differently this time to expect a different outcome? So that's why there's a picture of my trainers there. We have a duty of care to our patients to be sure that we're doing the right thing at the right time, because we have a footprint on our patients, and that restorative cycle is becoming more and more evident these days. The more heavy-handed we go, the earlier on, the less the patient has options in the long term. And I love an option. I love a backup plan, and a lot of my treatment planning is bearing that restorative cycle, maybe not in the short term, but definitely in the long term in mind. So when I'm taking a patient examination, detailed pain history, so Socrates is the best way to do that, because when you're dealing with pain can be misleading in certain circumstances, and the worst thing for a pain patient is that you do more surgery that's not going to help but actually exacerbate the pain. Obviously, a medical history is important, and patient compliance is extremely important. Now, please just screenshot this. I'm not going to go through all of these in minute detail, but the things that I'm going to highlight that are particularly important for periradicular surgery, you know, this isn't just an endo examination that we're doing. The smile line, you need to consider the smile line, because if you're going to make incisions, there are potential aesthetic compromises. The sulcus depth is going to determine how easy you can reflect your flap. Do not use a BPE probe. You need something like a PCP12 probe to investigate these teeth. And the sinus in relation to the location of the mucogingival junction is very, very telling. So assessing where that sinus is correctly is very important. You can screenshot this next slide as well. This is just discussing then from an endodontic point of view, a prosthodontic point of view, and a perio point of view, the individual factors that I'm assessing, so that we really know that once we've delivered that treatment, the tooth is amenable and restorable for the patient in the long term. It's not just a single specialty assessment we're doing here, and this is from a restorative point of view, for the patient's benefit. So screenshot that, and I'll talk you through the radiographic examination. Now, if there's one thing I love, it's a radiograph from two different angles and sticking a bit of GP in a sinus. So if you indulge me for a couple of minutes, when I look at a radiograph, we'll take the middle one. The first thing I look at is the intactness of the coronal restoration. So it's part of a bridge, but the marginal and coronal seal look pretty good. That looks like a pretty extensive post. It's either serrated or indeed threaded. It's a little bit short, so a good thing for removing it, but just from a point of view of application of forces, it's not so ideal. The obturation on beyond that is okay. That little void wouldn't particularly worry me, and it's pretty much to the length of the root. The external root surface, you can pretty much trace the PDL all the way along, which is great. There's no adjacent structures, but the cardinal thing here that I'm a wee bit concerned about is the radiolucency is not apical, it's more lateral. And this was originally referred in because it was like, is this a residual cyst in relation to the extraction of the lateral incisor? What's going on? There's a sinus suppuration. So what I did, very straightforward, just took a slightly different radiograph from a slightly different angle on the right-hand side, and you can quite clearly see that the post is off the long axis of the tooth, and what was a lateral radiolucency is actually, it is a lateral radiolucency. It's more in relation to that post having perforated. Now, you very rarely perforate with the actual post cementation. What you do is you perforate with the post preparation. And if I delete some of these, you'll maybe be able to see, if you look really closely, just at the radiograph, I'll highlight it, just here beyond the actual post itself, there's a radiolucency, and that's usually suggestive of the post has gone offline and actually it's popped out the root itself. So a radiograph from two different angles provides a vast amount of information such that you can come to a much more accurate diagnosis. The images on the left are from, I'll delete those lines, from this patient because they were referred because the sinus was associated, or the sinus was above the canine. You can see how close it is to the canine. This is an accessory point. It's an accessory B point. An accessory A point is just too flimsy to pop in a sinus and trace where the sinus tract goes. You can see my PCP12 probe. I'm going round the marginal integrity. I'm checking for periodontal pocketing, and there's none of that. The sinus is at the it's towards the apex of, or towards the sulcus depth, but it certainly is more towards the canine. But with the GP, we can definitely ascertain that it's associated with the premolar. And a different angle, most importantly, yeah, okay, we would all expect a 4 to have 2 canals, but what we can tell is that it's got 2 posts. And if you look at from the other angle, it's got an anti-rotational notch. So this is going to be bloody difficult to get out. Then, I'm going to be able to remove the GP most likely, so that's not going to be an issue. But the GP is just short of the radiographic apex, and that's potentially not a problem, as not all apical foramen are actually at the radiographic apex. But in a premolar with 2 converging root canal systems, that is probably most likely a little delta at the end of that. How am I going to guarantee that I can then negotiate that delta to make sure that I have apical patency, which is important for endodontic retreatment, especially with periapical radiolucency? So based on all those factors, then endodontic surgery is looking more appealing because of the difficulties that I can't guarantee with my orthograde dismantling of that. So I'm going to show you the next video. I'm not going to say a thing, and I'm going to ask you, I'll ask you the poll. So I'm going to ask you what the problem is, or what you think the problem is. I'll let you watch the video, and then I'm going to launch the poll. So this is the clinical situation. This is the radiographic situation. I'll have a look at the video. Okay, so Lorna, nice to see you. Lorna has asked a really good question: why PCP12 probe and not a BPE? And actually, hopefully this slide or this has demonstrated it nicely. I'm going to go back to the start of it, and I'm going to launch the poll. So here we go. What do you think the problem is? Poll launched. Yeah, so it's basically a split decision between root fracture and perforation. So right, okay, start. Excuse me, clinically. I've palpated up at the depth of the sulcus, up at the apex here, and the patient hasn't had any discomfort. This dirty big great sinus is at the level of the mucogingival junction, not where you would expect the apex of the tooth to be. In fact, it's this level is probably about this level on the radiograph. Then, when I look at the crown margin, it's not so hot. Certainly on the radiograph, the crown margin doesn't look so hot. And then what you saw was my PCP12 probe slide into about a 9mm pocket all the way to about there. So the reason the PCP12 probe is really important is because it doesn't have that ball on the end of it that your BPE probe does, and that ball really inhibits you finding very localized, isolated periodontal pocketing. So fundamentally, when I'm doing any type of endodontic assessment in my assessment kit is a PCP12 probe for that specific reason. I'll have a BPE probe just to take a BPE for the patient, but when I'm looking at that specific tooth, it's a PCP12 probe specifically for that reason. Then when you look at the radiograph, we've talked about the coronal seal doesn't look that hot. Let me just remove the red line. Can you see that the long axis of that post is slightly off the long axis of the root? Then we've got this little splash of most likely sealer. And then we've got a reasonable, yep, absolutely, a reasonable obturation, but we don't have any peri-apical radiolucency. So the peri-apical tissue looks normal to me. So altogether, when you look at this, the location of the sinus in relation to the tooth and the mucogingival junction, the post that's been offline, this is most likely a perforation. The additional finding of the fact that there's a periodontal communication with that perforation means that this tooth is pretty much unrestorable. One of the biggest factors for successful perforation repair is getting it isolated so that whatever you repair it with doesn't get washed out by moisture. If I was to dismantle this tooth and try and repair that perforation, because of the periodontal pocket associated with it, bugs would always get it back into it, and therefore saliva and moisture and GCF, and that would slowly erode my MTA or whatever material that I've tried to seal that perforation off with before it had even set. Therefore, even if you were to try to do it surgically, because you've got that communication, it's always going to be an area of compromise. You've always got that area of potential leakage, and so unfortunately that tooth is in this instance unrestorable. Okay, next one. So I'm going to ask you the exact same thing. What do you think the problem is? I'll play the video and then we can have a look at the poll. Okay, Sean, lovely to see you. I hope you're keeping well. You've mentioned as well you can't seem to see my slides when the poll is up. Apologies about that. Ryan, I'm sure, is working furiously in the background, and I'll let us know if we can do anything about that. But I'm going to launch the poll again just now. Yeah, so really sharp on this one. The vast majority of you root fracture. So if just for the sake of going through it, what you saw me do, I palpated the where the apex would be, and there was no discomfort. You then saw that I stuck my probe in a tiny sinus. So it's a small sinus, but it is again at that mucogingival junction. The crown itself looks relatively intact. It's a well-fitting crown, albeit there was a little bit of periodontal pocketing on this aspect. Most notably, though, you can see that there's a bit of a slipped contact. So this crown is sitting slightly labial, and you saw me getting the patient to go into protrusion for the occlusal contact of this, and this was the only tooth in protrusion. And it's maybe more obvious when you look at the radiograph, but fundamentally, one of the things I always ask myself is, why was this root canal treatment, post-core crown, whatever it was, done in the first place? Because the adjacent tooth looks pretty intact. The adjacent tooth looks pretty intact. the dentition itself is pretty well maintained for. The most logical reason is trauma. So all of a sudden you're thinking to yourself, okay, this is a tooth with a crown, which is by all means well fitting. The post is a long tapered post and reasonably well fitting within the long axis of the root canal system. The obturation is short of the apex a little bit, and we're not really sure about the periapical tissue. But with the mobility, so the cardinal thing at the end of that movie was, did you just see the very subtle mobility in the actual gingiva itself, not really the tooth? Then in relation to the small amount of pocketing, definitely the cardinal sign of the sinus at the mucogingival junction, lack of periradicular disease on the radiograph, a heavily restored tooth with a history of trauma, because certainly you can see there's pulp canal obliteration of the adjacent central incisor. A root fracture is by far and away your most obvious clinical diagnosis, and again, not adequate for, or not an indication for periradicular surgery. And in fact, if you look at the literature, approximately 47% of root fractures can be identified pre-operatively before you actually go on and do the surgery, so that you're avoiding unnecessary surgery. Now, the last one I want to show you, there's no poll associated with this. You've probably been asking, well, a lot of this could have been diagnosed from a CBCT. Yeah, to a certain degree, but how are you going to tell from this CBCT that this tooth maybe has a vertical root fracture or a perforation? Because all of that streak artifact and beam hardening, depending on the diagnostic quality of your CBCT, will have a heavy influence on the diagnostic quality of it. And while you may not be able to see an absolute fracture, what you would look for would be bone loss adjacent to a fracture. But again, you're not going to see that. All I can really tell is if you look in the top left, that again, there is no obvious periapical radiolucency. So when I'm looking at this tooth that's been endodontically treated twice, it's now heavily restored with a post. It's been to 3 different people for 3 different opinions about pain. When I go and examine the patient, I cannot precipitate the discomfort. PCP12 probe, no pocketing, no mobility. Small contact in ICP, no apical tenderness, no mobility, no sinus, no swelling. These are the red flags. These are the ones that you've got to think to yourself, I can't diagnose periradicular disease, so why should I be going and doing periradicular surgery? Because if this is a true persistent idiopathic dentoalveolar pain patient, by you going and doing surgery, you're going to really potentially put them in a bad situation of aggravating that discomfort. And I would absolutely suggest that you avoid doing anything else. It may be something mechanical that just hasn't shown itself yet, but that's fine not to do anything and reassure the patient. So what does endodontic surgery look like? Well, I'm just going to let this movie run. So this is where, when you open up the crypt, not just immediately try and tear that soft tissue lesion out. It's like removing the lining of an eggshell. If you go around the periphery of it and gently detach it from the bony crypt, you'll have a much better chance of getting it out intact in a oneer, and therefore to reduce any bleeding later on the surgery. Now what I'm doing is I'm removing the apex, because that actually helps remove the lesion, especially if the lesion is tracked down the palatal aspect of it. So going and removing your apex initially before you remove the lesion can be very helpful. And then you can see how it just pops out in one kind of deflated sac. What you'll notice palatally, can you see that accessory canal? So that's why the lesion is tracked down the palatal aspect of it. The grit on the ultrasonic tip is about 3 millimeters long, and just by gentle pressure, these tips are more efficient at cutting. If you put a lot of pressure on them, they will break. So all you need is access enough to get that in. I used 3 different layers of gauze, just 3 different slices of it, with local adrenaline-containing local anesthetic. Little tiny amalgam plugger. Dry it up with some sterile paper points. And then ready to receive the MTA. The worrying thing actually for me was over here, can you see the fenestration on the adjacent root surface? The gauze catches the MTA nicely, and then you can lift it out and you get some good hemostasis. Now, I don't want to go through this, but this is my surgical kit. So screen grab that. It's all from Hugh Freedy. Chris at Hugh Freedy, and will be able to point you in the right direction. Generally speaking, I have one kit for general surgery, and then I have a second kit that has little modules in it for, these are all the periradicular surgery ones. This is all the implant stuff, and where I've cropped it off was for the perio surgery stuff. So you need a couple of spoon excavators, you need a couple of little tiny amalgam pluggers, you need your front-facing micro mirror, and then it's really operator choice for the rest of the microsurgical instruments. This is an NSK handpiece, and now you can get them from W and H as well. But the most important thing is the angle of the head. It just allows you better visual access for your actual preparation of the root end. So that's a nice little handpiece to have with you. Flap design. There are many out there. I'm going to, what I really don't like to see is an incision that's designed at an acute angle away from the gingival margin itself, because this is what will happen. If you design your incision right at the biggest bulbosity of the tooth at a very kind of vertical angle, the chances of this necrosing, this little bit necrosing here, and then your approximation of it is very difficult. If you come out at 90 degrees each side and then go up, you've got all these little angles to nicely approximate with, and it's not on the most bulbous aspect of the root convexity. So you've got the minimal chance for recession. So, there are a lot of different surgical approaches, but your incision is exceptionally important, and thinking about the reasons why you're doing that incision are incredibly important, because adequate access, for example, this one down here is a papilla sparing incision, because you can see it doesn't include the papillae. But if your lesion is off to the side, when you've made that relieving incision, your flap isn't going to cover potentially your osteotomy completely, so that's going to really limit your access. Likewise, if you make 2 relieving incisions immediately, that again will very much limit your access and limit the blood supply to your wound. So my go-to and my preference, is the papilla-based incision. The other incision that I really don't like is the submarginal incision, so this one here. You can see the hideous scarring that it leaves. You're essentially suturing an alveolar mucosa, which is why it's scarring. Again, if you have a large lesion, it's very limiting in the access for it. But most importantly, the blood and nerve supply for your anterior maxilla comes down vertically like that. If you incise straight across it, you're cutting the maximum amount of blood vessels and neurovascular bundles, and you're increasing the patient's chance of, again, persistent idiopathic dentoalveolar pain. So for that reason alone, it is definitely not a flap of choice. My flap of choice is a papilla-based incision, which is split thickness, so it's in 2 different planes, and I'll show you that in a second. But there is good evidence to suggest that the papillae stays intact at the 12-month mark. So your initial incision is very much perpendicular. So you're tracing out a round incision on the papilla, and then this is my paramedian releasing incision. Then I'm coming back in and I'm on a much more parallel angle to the long axis of the teeth. So that's where I'm creating the split thickness aspect of it. And it's in a semicircle, because if you go straight across, it's again a wee bit more difficult to approximate when you're suturing. Then I'm going to come back and I'm going to make my intrasulcular incision, which is full thickness. And then for my relieving incision, I like a bigger blade because that 63 micro blade that I've just been using, the blade isn't long enough to puncture the sulcus properly, and then you end up tearing the soft tissue, and it's more difficult to obviously retract and then therefore approximate. So I do like switching my blade for a relieving incision. To elevate it, because it's a small incision and you don't want to crush the papilla and cause necrosis of the papilla, you're going to need to use something pretty small. So I like an Allen's elevator, or this is just the backside of a spoon elevator, or backside of a spoon excavator, sorry. But can you see my nurse is constantly irrigating? This is a fundamental part of surgery. The light from the microscope will heat up your surgical site really quite a lot and dry the tissues out quite a lot, which will increase your post-operative discomfort and possibly soft tissue necrosis. So because I'm using the microscope for all the surgery, you really do need someone irrigating to keep the tissues nice and cool, and also it helps your, keep the field of vision clean. Sometimes you'll have to dissect the lesion from the flap because it's perforated the labial plate, and that's quite common. But you just want to get a sound tissue margin for your retractor to rest on rather than resting it on soft tissue. And as you saw earlier, then start to how to remove that little soft tissue lesion from its crypt. Sometimes the lesion isn't, oh sorry, it hasn't, the lesion hasn't perforated the labial plate. So this is a round 5mm diameter diamond grit burr that I'm using, and you can see I'm accessing the lateral incisor. And at this point, I'm thinking, oh dear, where's the periradicular lesion? Like, have I accessed the wrong tooth? So again, I go and remove the root end, and because a lateral incisor that tips palatally, you can now see the actual lesion is or was palatal to the root tip itself, and then you can debride that. To debride it effectively and not leave tissue strands will help you with hemostasis. Can you see how it's dried up nicely? So if you leave soft tissue tags, you'll leave little bleeders within the crypt. But you can see quite clearly there the chromogenic staining of the root canal system. So you know you're onto a winner already. Again, ultrasonic instrumentation, you need enough access to get that actually into the canal. So sometimes you do have to increase the size of your osteotomy slightly. And you will always leave a little bit of labial tissue, or sorry, a labial GP. It's notorious because you lose your orientation with the ultrasonic. It's very easy to leave that. So your micromirror, you can see how it pops out nice and easily. And you know that you've resected the GP back by at least 3mm equally down into the canal. Now, why do we do 3mm resection? Well, as I said previously, all those little anastomoses, accessory canals, portals of exit, are mostly 93% of them are in the apex, in the apical 3mm. So that's why we're lobbing off 3mm to get rid of all those bits and pieces. Now you can use methylene blue, and methylene blue is really good for indicating cracks, but the way it does it is it stains up the PDL, and if there's a break in the PDL, that's when you can identify a fracture, okay? So that's what you're using methylene blue for. It'll also identify little bits on the root end itself, but you're staining up the PDL so that you can see any disharmony or junction in the PDL that would indicate a root fracture. Isthmuses, premolars, pain in the backside. An isthmus will reduce your success of periradicular surgery. So it is critically important that you're properly accessing the root end and you're opening up that isthmus between the buccal and the palatal canal. Sometimes I even use the ultrasonic just to polish the root end from a horizontal point of view as well, just after the resection. You don't want to leave any sharp edges because sharp edges, healing tissues don't like sharp edges. And in a second, you're going to see when I put my micro mirror in, the buccal GP and then the separate palatal GP and the isthmus that I've opened in between both of them. So can you see, there's the buccal and there's the palatal. Buccal, palatal, and then the big isthmus between them. Again, gauze in the background, nice hemostasis. paper points, dry up the canal, ready to receive your retrograde restoration. Now, just a quick point on endodontic surgery the second time round. There is no need to resect another 3 millimeters, all right? Once you've resected the 3 millimeters, you've got rid of all those little accessory canals, so there's no reason to resect a further 3 millimeters. In this case, it wasn't done at 90 degrees, so you can see how I've increased the 90-degree perpendicular resection. But when you actually look at the end of the post, because that's a fiber post in there, when you look at the end of this post in a second, you'll see that it's black. It's poaching in bugs again. So now what I've got to do is I've got to start and remove a bit of a fiber post with my ultrasonics, which takes more time, but is doable. You can't start to remove amalgam. You can't start to remove a metal post with the ultrasonic tips like that. They just don't function to do that. Their function is to remove the dentine and GP, and to a certain extent, that's a fiber post in there, so it will remove that to a certain extent. So just to say, if you're ever going to consider repeat surgery, it is unnecessary to take off another 3 millimeters. But as I said, you can't always identify fractures first time round, and you can just see the fracture line there, then extending up that way. So this tooth has, unfortunately, we haven't been able to identify the fracture preoperatively, but intraoperatively, we have identified a fracture. That's got nothing to do with the ultrasonic preparation. As I said, you're using very gentle, light pressure, and we know that the ultrasonic preparation won't create a fracture, but if a fracture is there, it may propagate it. So in that case, we're putting a root end restoration on anyway, and really we're counselling the patient on rapid alternative prosthetic options. The other thing that I briefly touched on when you're looking at the radiograph is local anatomy. It's a very big canine. You can see the Schneiderian membrane moving up and down. It's unusual for your periapical lesion to perforate the nose, to perforate the sinus. What happens is the soft tissue just kind of gets a bit stuck to whatever membrane that it's approximated against. And if you can gently peel that away, you can usually maintain whatever the soft tissue is on the other side, like you see there. I have no interest in doing sinus augmentations. I really don't want to play around with trying to repair a hole in the sinus. So gently does it. What are the options for your retrograde restoration? Well, historically, the two on the left, more contemporary, the two on the right. Is there any evidence that one's better than the other? Yes, there is, and it also takes into consideration, this surgery is a mosaic of different elements. Just because you stick in MTA into a surgery that you haven't planned correctly and you haven't executed the rest of the procedure well, the MTA is not going to save you. Likewise, if you've done the surgery really well but stick in IRM or something like that, that again isn't going to save you. This is a mosaic of small pieces that marginal gain stuff, if you like sports science, to achieve the kind of optimal outcome. And recently, the putty, so the putty is a bioceramic putty. It's a lot easier to handle than MTA, a lot easier to handle. Until recently, it was mostly animal studies, but even on CBCT diagnosis of healing, so SAFI, last year, it was a 92 versus 95% success rate. So the bioceramic putty is definitely an alternative, a successful alternative, and also from a procedural point of view, it keeps the procedural time down and is just easier to manipulate. Now, a niche bit of info about periradicular surgery and retrograde restorations. Some people are squirting in the sealer and then putting a little lid ceramic putty on top of it. I don't see the point in that, but you'll maybe see it as an option out there, and just for completeness. When you're using MTA, it needs to be in this consistency to properly pack it, so it needs to stand by itself. It can't be wet. And then because it's MTA, you need to bring in your little amalgam pluggers, and you need to plug, come back with more MTA, stuff it on, plug. come back with more MTA, stuff it on, plug, 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 and a lot of it will spill over. But you can see if you put the gauze in the crypt, the gauze will catch it. So when you lift out the gauze, then most of the MTA comes out. And when you rinse it with saline, it washes off just the superficial layer. So that's why you saw me just add in a little additional layer at the top. And what you do not want it smeared out over the root face, because that inhibits all those little cementogenesis cells popping onto the root surface and creating cementum and potentially a PDL. You just want it in the canal itself. The putty, as you'll see, is a lot easier. This is the first time I actually ever used putty, and I probably used enough for about 5 cases. But you can see the retrograde preparation. Nice resection on the GP. This, and I think it's MTA, and the amount I've got on the actual flat plastic. So a reasonable amount of it went to waste there. But you can see how it's a lot cleaner. You don't get the spillage. It's a lot easier to handle. You don't have to have a proficient nurse at mixing it, because that's extremely important with MTA. You have to have your nurse mixing it 5 minutes before you want to do it. The MTA comes in a little pouch. You scoop a bit out and you stuff a bit on the apex, and you can easily mop it up. And you can see how the apex, or the apical root surface, is a lot cleaner than what you've got with MTA. So there are a lot of functional advantages to it, and now the histology has eventually caught up, showing that we have equivalent success rates between MTA and a bioceramic putty. Just briefly to suture, because I think this gets left out a lot. So this is 6-0-proline. When you've made a papilla-based incision and you've made a little V across the papillae, you can see that I'm suturing it from both sides, okay? So that I get maximum approximation of the flap, so that I end up with minimal scarring in the long term and a couple of sutures for the relieving incision. So that's how it should come together. The papillae are still nice and pink. Everything's approximated nicely. And I take the sutures out about 5 days later. I'm not going to go through each individual case that we talked about, but generally speaking, those are the success rates quoted in the literature. So historically, from maybe an apicectomy, there is a significant improvement from 60% up to 86% for contemporary surgery. And that's what I'm saying. This is a mosaic of small little steps that have all individually improved. You can't put it down to just one individual step. Resurgery is generally successful, but it's something, again, if you're going to do something over and over again, you've got to really question yourself, what different outcome are you going to expect? So I don't do a lot of resurgery, to be honest with you. And I suppose because I'm restoratively trained, and there are many alternative prosthodontic solutions that are, again, very successful. Coming to the last 2 minutes, I know I'm slightly over my time, but I just thought, what are the hot topics in periradicular surgery? So grafting. So you'll see a lot of people stuffing in BioOS and BioGuide into your crypt. Does anybody have experience of that? Because this is the last poll. Or would you bother grafting this lesion? Okay, so yep, more than 50% of you have voted. I'm going to assume some people have kind of wandered off. The vast majority have said no, and I agree. So I worry sometimes that endo feels like it's getting left behind with all the advances in GBR, so bone regeneration, implants, bits and pieces. If you look fundamentally at the historical perio literature about what defects will have the best chance of healing spontaneously, they are 3-walled defects. So a defect with only 1 wall missing, they have maintained their 3 other walls. And if you think about, I'll play this video, if you think about a crypt, it only has usually the labial surface missing. So that crypt is nicely contained, that you'll get a nice stable blood clot and you'll get healing. So fundamentally, from a biology point of view, I don't particularly see the advantage in grafting, except possibly when you're looking at a through and through lesion. So can you see just here, this is the soft tissue of the palate. Potentially, if I now put a bit of a membrane over that and put some, BioOS and BioGuide in there, I might get better regeneration than I did, because this is essentially forming the scar that we talked about in the first or second slide. But if I immediately stick something radio opaque, if I had stuck something radio opaque in here immediately, I wouldn't have been able to assess any healing at any follow-up appointment, because it would have all been radio opaque BioOS. And after that, then you've got to ask yourself, well, okay, is it going to make a difference if I'm going to have to pop an implant in there at any other point? There's no good long-term evidence to suggest that me grafting that at this time of the periradicular surgery, that I'm going to get a better success for my implant. And then when you think about the complications, if any of you do surgery, if you're going to do a bone graft, would you do a bone graft immediately on an area that was just dripping in pus? Because essentially that's what we've done. We've lifted out a chronically infected lesion, potentially with a sinus that's dripping pus, and you're then going to go immediately and do essentially a bone graft to it. I'm not sure that a lot of people would be comfortable doing that. So from a biological point of view, generally, I don't see it as a big advantage. And certainly in large lesions either. You can see that this was a huge lesion. It didn't communicate with the nose, and that was after 2 years of healing. We got a significant reduction, but I can monitor that reduction because I know that that's the body's own native bone that's in there. I don't know the percentage BioOS to native bone at 2 years if I had a bit BioOS in there. Other little surgeries on the left, you can see the preoperative radiographs. This was a perforation on the lateral incisor, and there was GP stuffed out the apex. So what I've done is I've gone and removed as much GP as I can non-surgically, and I've repaired the perforation with MTA because it didn't have a periodontal communication, because you can see sound bone there, but that's my MTA. So I've removed the GP because it didn't heal because there was GP stuck there. But because I'm there, all I'm doing is I'm doing a little bit of polishing of the root end and my MTA, just to make sure that that seal is completely intact. And you can see on the right-hand side the post-operative healing from the periapical radiograph. And finally, if you're interested, I did a lecture recently on this for dental traumatology. This is external cervical resorption. So we see quite a lot of external cervical resorption. I've seen about 81, well, 81 exactly, I've seen over the last 2 years, because that's what we've put in for publication. So external cervical resorption, the gingiva essentially invades the tooth itself, nibbles away at the tooth, and it leaves this hollow. But you can just about see some dentine protecting the pulp, so that's great. What I'm doing is I'm trying to chemically disinfect the area, because there's lots of little multinucleated giant cells and clastic cells in there that's nibbling away that dentine. So I need to disinfect it properly, and then you're putting on a restoration and suturing the gingiva back. Something that I haven't done is dynamic surgery. Again, whether implants are taking the lead on this, but there's a lot of dynamic guided or actual surgical guides now for periradicular surgery, mostly for lower molars, but to be honest with you, I have no interest in faffing around someone's mental nerve or ID nerve. But I do a lot of social media, and that's the social media address for the guided stuff. I would recommend that you have a look at Endo in Practice for some more interesting endo stuff. And that's really the end of what I've got to chat about. Those are some further references